decreased incretin effect, and there is increased lipolysis. These are all the pathways which are responsible for the development of diabetes, and we have now developed drugs which act on all of these pathways and have helped in improving this hyperglycemia. We will talk about them as we go, as we talk about the drugs. So first thing to do is the diet. Dietary advice which should be given to the patients is that their fat should be provided 25 to 35% of total intake of calories, and saturated fat intake should not exceed 10%. Cholesterol consumption should be restricted to 300 milligrams or less daily. Protein intake should be 10 to 15% of the total energy requirement increase for children during pregnancy. It should be derived from both animal and vegetable sources. Carbohydrates 50 to 60% of total caloric content of the diet. Carbohydrates should be complex and high in fiber. So it should have high glycemic. It should have low glycemic index. Glycemic index is when you take a food, the rapidity with which the glucose levels rises in the body is the glycemic index. So sugar you take and it will shoot the glucose levels at a very rapid rate, so it has a high glycemic index. And the food, their glycemic index is compared to that of slice of a white bread. So the way white bread causes the rapidly raises the blood sugar levels is considered 100%, is considered the highest glycemic index. So drugs, the food, the food substances which when you take, they raise the glucose levels slowly and gradually. Those kind of foods are known as low glycemic and are known to have low glycemic index. So, and what are these foods? These are complex foods like your um, the ones with the high glycemic index is grapes and the watermelon, and which are highly sugary foods, while those like the vegetables, they have a low glycemic index. You can look up for the hyperglycemic for the glycemic index, high and low glycemic index foods, and they you can easily get these from the net, tables or charts from the net. Excessive salt intake is to be avoided. It should be particularly restricted in people with hypertension and patients with nephropathy. Physical activity is very important. It helps reduce weight and improves the insulin sensitivity. So with dietary treatment and a regular physical activity helps the patients and in controlling their sugars. But it should be according to individuals' health status and fitness. So before advising exercise, you have to rule out and you have to look for the complications. The autonomic dysfunction, the cardiovascular disease, and the retinopathy is very important to know. Patients need to be educated about the incidence of hypoglycemia. So because if the patients start doing exercise, maybe the requirement of the insulin, if he is taking insulin, then the requirement of insulin might go down. And if he keeps on taking the same dose, there are chances that he has hypoglycemia. So patient has to be educated before he starts the exercise. So we have anti-diabetic drugs. As I said, they act on all the octet of the type 2 diabetes. So we have insulin, the drugs which causes increased secretion of the insulin. Yeah, that group is sulfonylureas, meglitinides, and incretins. Then there are drugs which, some of the drugs like incretins also play an important role in decreasing the glucagon secretion. Then incretins have effect on the GI, and they causes the GI, the gastrointestinal system, and we have alpha glucosidase inhibitors over there, which inhibit the absorption of the glucose, amylin and bile acid sequestrants, which can again lead to decrease the hypoglycemia. Metformin thiazolidinedione decreases hepatic glucose output and thus decreases the insulin resistance. Thiazolidinediones also affect the fat cells and decreases the production of glucose. Glucose uptake and utilization is increased by means of thiazolidinediones and metformin, so they are helpful in insulin resistance. Glucose reabsorption is inhibited by the SGLT2. So here the newer drugs which we have been knowing about sulfonylureas and metformin, thiazolidinediones, even the bromocriptine, it acts on the brain and has a neurotransmitter dysfunction which occurs in the brain. If dopamine system, it affects that, and through that it helps in decreasing the hyperglycemia. So we have been knowing about these for decades and decades. These are the drugs, this SGLT2 inhibitors, and these are the incretins, which have completely changed the face of the treatment of diabetes. And diabetes is now going to be, in few years, the monotherapy, the first line drugs, they might be changed to these are the dual drugs which might be replacing the old ones in coming future. So sulfonylureas stimulate the pancreatic secretion of the insulin. There are several generations of these. It is about so first generation is tolbutamide, chlorpropamide, and acetohexamide, which are low potency drugs, more potential for drug interaction side effects. Second generation is glimepiride, glipizide, and glyburide. They are higher potency, less for drug interaction side effects. All sulfonylurea drugs are equally effective in reducing the blood glucose when given in equipotent doses. So the duration of action is highest for chlorpropamide for 24 to 60 hours. They have active metabolite. The glimepiride is the one which is usually prescribed nowadays. It's a 24-hour duration. We can give 1 to 2 milligram. Glyburide or glibenclamide is the one which is being given advice in pregnancy as well. They reduce HbA1c by 1.5 to 1.7%. Fasting plasma glucose reduction is by 50 to 70, and postprandial is by 92 milligram per dl. Adverse effects is by the main adverse is hypoglycemia. That's very dangerous. In old age, most of the patients we have seen coming with hypoglycemia because of this. And then there is a problem of weight gain with this drug. Hyponatremia with tolbutamide and chlorpropamide has been seen. There also have several interactions with warfarin, salicylates, chloramphenicol, allopurinol, and propanacid. Then we have short-acting secretagogues, repaglimide and netaglimide. They cause insulin. They cause a glucose-dependent insulin. And so what happens, they cause the release of the insulin when there is glucose in the body, excessive glucose, and this insulin secretion is decreased at low glucose level. With lower potential of hypoglycemia, they have to be given before meal or with the first bite of each meal. If you skip meal, you don't need to take this drug, so it will only cover if the glucose is raised. Adverse effect, there is incidence of hypoglycemia is there, but it is low. Inducers or inhibitors of cytochrome 3A4 affect the action of repaglinide, and letaglynide is inhibitor of the cytochrome 2C9. Bigonides, the metformin drug, glucophage, which is the drug of choice, loved by all the physicians, all the dietitians, all the diabetologists, everyone, all the endocrinologists. Metformin. What does it do? Reduces hepatic glucose production, increases peripheral glucose utilization. It causes nausea, vomiting, diarrhea, anorexia. So you have to build the dose in these patients. You have to you start with a light dose and then you bring it to the maximum dose, 3 times daily maximum dose. Fenformin was another biguanide which was taken off because it caused lactic acidosis, and because of this, the metformin should not be used in patients with renal insufficiency, congestive heart failure condition that leads to hypoxia, and that is also the reason that metformin is usually stopped in all those patients who had myocardial infarctions, a heart attack. So it is stopped for usually for 6 weeks after the myocardial infarction to prevent the incidence of lactic acidosis. Glitazones or thioglitazones, these are p-bar gamma agonists. This is paroxysine proliferator activated receptor gamma agonist. Rosiglitazone and pioglitazone, very effective. They reduce insulin resistance in periphery by sensitizing the muscles and fats to the action of insulin and possibly in the liver. Onset of action is slow, 2 to 3 months, causes edema and weight gain, and that is the reason that it is not prescribed in patients with congestive heart failure. They had a very good effect and were frequently prescribed. Their use has gone down because of the high reported increase in incidence of the bladder cancers with it, and it also causes osteoporotic fractures. However, now newer studies are coming which are refuting the claim that there is increased incidence of the bladder cancers, and but still clinicians are reluctant to use these drugs. And now there are other drugs in the markets which have much better beneficial effects, which are now being prescribed. So we have glucosidase inhibitors. Sorry, this is a little dark in color. So we have acarbose and meglitolol. What they do is they prevent the breakdown of sucrose and complex carbohydrates and thus decreases the postprandial glucose rise. It is effect limited to luminal side of the intestines and limited systemic absorption. So it doesn't cause systemic absorption. It remains within the gut, and that's why it's eliminated in feces. Reduces the postprandial glucose. Average reduction of the HbA1c is 0.3 to 1%. The main side effect of alpha glucosidase is it causes a lot of flatulence and a lot of abdominal pain and gaseous distension, because it is preventing the breakdown of the sucrose and the complex carbohydrates, which are then broken down by the bacteria down in the large gut. Insulin, very important drug. The last drug which is usually patients think that when insulin is given, it's end of the life, it's end of the diabetes, there is nothing else could be done for the diabetes. But insulin is one of the best drugs which a patient can have, because it is the physiological thing which will be given. This is the thing which body is secreting, and this is the thing which has reduced, is not there in the body anymore in diabetic patients. So insulin is the magic drug for these patients. It is the life drug for these patients actually. So insulin has anabolic effect of glucose uptake, glycogen synthesis, lipogenesis, protein synthesis, and triglyceride uptake. Anticatabolic is inhibit gluconeogenesis, glycogenolysis, lipolysis, proteolysis, and inhibit fatty acid oxidation. The insulin commonly available is the U10, U20, and U100. We have the U100, the one while having 100 units of insulin in it. So there is pork. Source is either pork or human insulin. This is no more in use because it used to produce antibodies. Now this is the recombinant DNA technology, and human insulin is the one which is commonly being prescribed. The pork one is no more, or beef pork is no more in practice. Onset and duration of effect, change in the properties of insulin preparation. So if insulin molecule is changed